Hi, hello everyone. I'm Dr. Srilakshmi from Usmania General Hospital. Here is a small video on role of imaging in pneumoconiosis. Please do like my video, subscribe my channel and share it with your friends. Thank you.
This is
Bye
Dr.
bye.
Srilakshmi, a budding radiologist. Today's topic is role of imaging in pneumoconiosis. Damage to the lungs caused by dust, fumes, noxious substances inhaled by the workers in certain specific occupations are termed occupational lung diseases. Pneumoconiosis is the term used for the diseases associated with inhaling mineral dust. The severity of the disease is related to the material inhaled and the intensity and duration of exposure. Even individuals who do not work in the industry can develop occupational disease through indirect exposure. Now coming to pneumoconiosis, it is caused by the accumulation of inhaled particles and involves a reaction of tissue in the lung. The reaction of the lung to involved dust depends on various factors of the particles such as size, shape, solubility and reactivity of the particle. Based upon the size of the particle, they are categorized as if it is from 5 to 10 micron meters, it is very unlikely to reach the distal airways. If it is 1 to 5 micron meters, then there are many chances that they get lodged into the distal airway. And if the size is less than 0.5 micron meters, then there is no substantial deposition and henceforth no injury. Classification is based upon whether fibrosis occurs in the due course of the disease or not. So, accordingly, we can categorize them into fibrotic and non-fibrotic types. Under the fibrotic type, it includes asbestos-related diseases, silicosis, coal-workers pneumoconiosis, berylliosis, and talcosis. Under the non-fibrotic group, it includes siderosis, stenosis, and barytrosis. Then coming to asbestos-related lung diseases, first of all, asbestos fibers are of two types. They are serpentine fibers. The example is chrysolite, which is also known as white asbestos, and the next type is amphibial fibers. The example are crocodilite and amosite, which are known as blue and brown asbestos respectively. The asbestos related diseases include those affecting the pleura and the lung parenchyma. The pleural manifestations include pleural effusions, pleural plaques, diffuse pleural thickening, interlobar fissure thickening, and malignant mesothelioma. Under the lung parenchymal manifestations, they include round cell atelectasis, asbestosis, and bronchogenic carcinoma. First of all, coming to the pleural manifestations, the pleural effusion. The benign pleural effusions are thought to be the earliest pleural manifestation in an asbestos exposure. They usually occur within 10 years of exposure, but they can also develop much later. Effusion is usually of hemorrhagic exudative nature. Patient of asbestos exposure where you can see there is a blunting of the right CP angle which is consistent with effusion. Then the next manifestation is pleural plaques. The most common manifestation of asbestos exposure is pleural plaques. They tend to occur 20 to 30 years after exposure. The classic distribution of plaques seen on the chest radiographs is as follows. They mostly involve the posterolateral aspect of the chest wall between the 7th and 10th ribs, the domes of the diaphragm. Virtually, this is a pathognomonic feature of an asbestos exposure. And also it may involve the mediastinal pleura. They are usually bilateral and symmetrical in involvement. They can be discrete, smooth or irregular. They are discontinuous in nature and sometimes they may calcify. This is a chest X-ray PA view where you can see the plaques noted along the lateral aspects of the lungs and also in the bilateral diaphragmatic pleura and also along the mediastinal pleura. This is a similar chest X-ray in another patient where you can see a plaque noted along the mediastinal pleura. The next manifestation is diffuse pleural thickening. Diffuse pleural thickening is less specific for asbestos exposure because other causes of exudative effusions can also lead to it. Diffuse pleural thickening on chest radiographs can be defined as those with smooth, uninterrupted pleural opacity extending over at least 1/4 of the chest wall with or without obliteration of the CP angle. CT criteria of a continuous sheet of pleural thickening measuring more than 5 cm in width, more than 8 cm in craniocaudal extent, and more than 3 mm thick is defined as a diffuse pleural thickening. The differential diagnosis for diffuse pleural thickening includes organizing effusion, chronic infection, for example tuberculosis, connective tissue diseases, talcosis, pleural metastasis, and mesothelioma. CT chest at the level of arch of aorta in the mediastinal window showing pleural plaque which is calcified. This is an axial CT in a mediastinal window of other patient of asbestos exposure where you can see the pleural plaques along the posterior aspect together with the calcification in the pleural plaques at the paravertebral location. Axial CT chest in a patient of asbestos exposure in the lung window where you can find pleural thickening along the anterolateral aspect together with linear hypertense band-like opacities extending into the lung parenchyma. CT chest mediastinal window in a patient of asbestos exposure where you can see the left pleural effusion together with the diffuse pleural thickening along the posterolateral aspect of the pleura. An axial CT chest mediastinal window in a patient of asbestos exposure where you can find diffuse pleural thickening noted along the posterolateral aspect of the pleura together with the thickening extending into the major fissure. This is a chest X-ray PA view in a patient of asbestos exposure together with the corresponding axial CT in the mediastinal window showing blunting of the left CP angle which is corresponding to the pleural thickening on the axial CT. The next manifestation is round atelectasis. It occurs due to an inflammatory reaction and fibrosis in the superficial layer of the pleura. As the fibrous tissue matures, it contracts, causing pleura to fold into the lung, which in turn causes atelectasis. Asbestos-related round atelectasis is also known as Blisowski's syndrome or a pseudotumor. The major differential diagnosis for round atelectasis includes lung cancer. This chest X-ray PA view in a patient of asbestosis where you can find pleural thickening noted along the lateral aspect together with subtle radio opacity in the right midzone. This is an axial CT in a patient of asbestosis in the lung window where you can see the thickening of the pleura along the anterior aspect together with an adjacent round or oval mass like density which is abutting the adjacent pleura. Together with that you can see a comet tail appearance of which is given because of the vessels which are traversing towards the mass. This is a classic feature of a round atelectasis where you can see a comet tail appearance which is given by the vessels which are traversing towards the mass together with the adjacent pleural thickening. This is an axial CT in the lung window in a similar patient where you can find the pleural thickening with an adjacent rounded mass with the vessels traversing towards it, which is again a classical feature of round atelectasis. CT chest in the lung and the corresponding image in the mediastinal window showing evidence of diffuse pleural thickening noted along the posterolateral aspect of the pleura together with the adjacent rounded mass together with the vessels traversing towards the mass consistent with round atelectasis. The images in a patient of asbestos exposure which are taken in a sagittal and the axial corresponding axial images. These are the post contrast images where you can find homogeneous enhancement of the tissue over here together with the contrast opacified vessels which are moving towards the parenchyma which is consistent with round atelectasis. Manifestation in a lung which includes asbestosis. It includes lung fibrosis which may or may not be associated with pleural fibrosis. It is caused by asbestos dust. There is a dose-response relationship between exposure and severity of fibrosis. The lag between exposure and onset of symptoms is usually 20 years or longer. Sometimes it may even be more than 40 years, but sometimes it can be very little as 3 years in cases with constant heavy exposure. Location. It is usually pronounced in the lower lobes and subpleurally in non-dependent locations. Often it extends to involve the middle lobe and lingula. Upper lobes can be involved in advanced cases. Honeycombing, as in other fibrotic lung diseases, can occur in advanced disease. Chest X-ray PA view in a patient where you can find a nodular opacities in the left lung in the mid zones, and also you can find some reticular opacities together with the irregular mediastinal and the diaphragmatic borders on the bilateral sides, which is classical for a patient in asbestosis where there is predominance for the involvement of lower zones. This is the close-up view of the same image which we have seen in the previous slide, where we find reticular opacities in the bilateral lower zones along the mediastinal and along the pleural surfaces of the lung. This is chest X-ray PA view in a patient of asbestos exposure where you can find linear opacities extending from the pleura into the parenchyma of the lung together with blunting of the left CP angle. These are the parenchymal bands. Axial CT in the lung window where you can find pleural thickening noted along the lateral aspect together with subpleural curvilinear opacities in the lungs. This is an axial CT in the lung window in a patient of asbestos exposure where you can find linear hyperdense bands extending from the pleura into the parenchyma which are consistent with the parenchymal bands. This you can find in the bilateral lung fields over here. This is an image of axial CT in the lung window where you can find ground glass opacifications noted along the subpleural locations. This is a coronal CT image in a patient of asbestos exposure where you can find multiple dot-like opacities noted in the subpleural locations which are further coalescing in order to form the curvilinear lines, which is one of the parenchymal manifestation of asbestosis. In the same image you can find the interlobular and intralobular septal thickening. This is the axial CT chest lung window where you can find subpleurally located honeycombing pattern in the lung. This manifestation is malignant mesothelioma. Malignant mesothelioma occurs mainly in the pleura and peritoneum but can arise in the pericardium, tunica vaginalis of testis. Malignant mesothelioma is the most common primary neoplasm of the pleura. It has a strong association with asbestos exposure, particularly crocodylite. It has a latency of 30 to 40 years from the time of exposure. The tumor can arise from either of the pleural layer. It is often associated with an effusion. As it enlarges, it causes pleural thickening and eventual encasement of the lung with retraction of the chest wall. Direct spread into the pericardium, contralateral pleura and peritoneum occurs. Lymph node spread and bloodborne metastasis to the lungs, liver, kidneys and adrenal glands may occur. Differentials include diffuse pleural thickening due to infection and also metastatic adenocarcinoma. This is a chest X-ray PA view in a patient where you can find blunting of the left CP angle which is consistent with effusion. Together with that you can find some lobulated opacities noted along the pleura. This is the axial CT chest in a patient of asbestos exposure where you can find nodular enhancing pleura together with the nodularity extending into the fissure, and also there is encasement of the pericardium and there is invasion of the chest wall. This is a case of malignant mesothelioma with the extent as described. This is axial CT chest in the mediastinal window in a patient of asbestos exposure, where you can see the mass which is extending into the chest wall. A similar case where you can see the pleural mass with showing heterogeneous enhancement together with invasion and encasing of the adjacent pericardium. This is a case of malignant mesothelioma where you can see there is loss of plane with the liver and also there is infiltration into the liver. So this is a spread of the malignant mesothelioma into the liver. A similar case of malignant mesothelioma where you can find the mediastinal encasement together with the mediastinal lymph nodal enlargement. This is another similar case of malignant mesothelioma where you can find the lesion over here with a metastatic deposit in the contralateral lung. Last manifestation of the asbestosis is bronchogenic carcinoma. Here you can find the difference where there is heterogeneous enhancement in the lesion, which is a contrasting feature compared to the round atelectasis where you find a homogeneous enhancement of the mass, and there is no such comet tail appearance, which is because of the vessels that are moving towards the lesion. Here there is no such appearance. So this is a case of bronchogenic carcinoma in a patient of asbestos exposure together with the bilateral pleural plaques with the calcification. Then coming to silicosis, it is caused by the inhalation of fine particles of crystalline silicon dioxide. Quartz is the most common form of crystalline silica. Occupations such as mining, quarrying, and tunneling are associated with silicosis. Carcinoma and tuberculosis are potential serious complications of silicosis. Then coming to the clinical forms and features of silicosis. First of all, acute silicosis. Here the patient presents with cough, shortness of breath, pleuritic chest pain following large exposure of silica dust. Histopathologically, there will be severe alveolitis with alveolar filling leading to alveolar lipoproteinosis. Then in a chronic silicosis can be classified as chronic simple and chronic complicated silicosis, where the patient may be mostly asymptomatic in the case of chronic simple silicosis, and if at all he is symptomatic, the symptoms may be exertional dyspnea and cough with expectoration. Histopathologically, there will be mature collagen at the center with peripheral macrophages. Then in a case of chronic complicated silicosis, there is progressive dyspnea and productive cough. The patient may also have malaise and weight loss. Histopathologically, there are large conglomerate lesions with multiple foci of collagen and peripheral macrophages. Axial CT chest in a lung window showing evidence of interlobar septal thickening and also fine ground glass opacification in the left lung. This is in a patient of acute silicosis who is 52 years old, who worked for about 10 years as a crystal craftsman. This is axial CT chest in a patient of silicosis where you can find areas of ground glass opacification and also areas of consolidation. Case of acute silicosis where you can find areas of ground glass opacification in the bilateral lung fields together with the interlobar septal thickening, which both of them combinedly giving a crazy paving appearance, which is seen in acute silicosis. CT chest in a lung window where you can find multiple nodular densities which are of uniform sizes noted in the bilateral lung fields in a patient of silica exposure. Chest X-ray PA view in a patient of silicon exposure where you can find multiple nodular opacities of uniform sizes in the bilateral lung fields. Coming to the findings in a patient of chronic simple silicosis where you can find multiple tiny nodular opacities in the bilateral lung fields which are usually of uniform sizes, that is from 1 to 10 mm, and you can find calcification in these nodules which occur in about 10 to 20% of the cases. Axial CT showing multiple nodular opacities of uniform sizes in the bilateral lung fields, few of them coalescing. Coming to the complicated form of silicosis. Complicated silicosis, also known as progressive massive fibrosis, develops through the expansion and confluence of individual silicotic nodules. Lymph nodes show axial calcification in simple and chronic silicosis. In order to call a lymph node calcification as an axial, it needs two criteria. They are at least two of the lymph nodes should be present, of which one of them should be at least 1 centimeter in diameter, and at least one of the node should have a complete ring of calcification of thickness up to 2 mm. X-ray PA view in a patient of silicon exposure, where you can find nodular opacities in the bilateral upper zones together with multiple enlarged nodes in the bilateral hyla, where few of them are showing peripheral calcification which is consistent with the axial calcification. Axial CT image showing multiple enlarged lymph nodes with the peripheral calcification, which is known as axial pattern of calcification in a patient of silica exposure. Chest X-ray PA view in a patient of silica exposure, where you can find hyperlucency in the bilateral upper zone which is consistent with the emphysematous changes, and bilateral mid-zone asymmetrical irregular patchy pulmonary opacities. Axial CT in a lung window in a patient of silica exposure, where you can find multiple nodular opacities in the bilateral lungs together with a large symmetrical densities with irregular margins which are moving towards the hyla. In the image also shown is the interlobar septal thickening. This is an axial CT in a lung window in a patient of PMF, where you can find peripheral areas of emphysematous changes together with bilateral fibrotic areas which are moving towards the hyla. Silicotuberculosis. Pulmonary tuberculosis occurs in 25% of the patients with acute or classic silicosis. It is 2.8 times more prone than that of the normal patients. How to identify the onset of tuberculosis in a patient of silicosis? It is by these manifestations: the occurrence of pleural effusions, consolidations, infiltration, and cavitation in an already known case of PMF. Then we need to think about onset of tuberculosis in a patient of silicosis. This is an axial CT chest in a lung window, where you can find cavitation. Coal workers pneumoconiosis. Coal workers pneumoconiosis is caused by exposure to washed coal which is nearly free of silica. The radiological findings in coal workers pneumoconiosis and those of silicosis are similar, and the two diseases cannot be easily distinguished from one another on images. The risk of tuberculosis is increased in individuals with coal workers pneumoconiosis. Here, a paradox to be remembered is coal workers pneumoconiosis actually decreases the risk of lung cancer. Simple coal workers pneumoconiosis has more incidence of lung carcinoma compared to progressive massive fibrosis. Coal dust inhalation also is related to the development of chronic obstructive pulmonary disease. It occurs in two forms. One is the simple form and the other is the complicated form. Clinically, most patients with coal workers pneumoconiosis are initially asymptomatic, particularly those with the simple form. Whereas in a patient with complicated form, he usually presents with the symptoms of cough and dyspnea. The progressive massive fibrosis usually involves posterior segment of upper lobe and superior segment of lower lobe, and then they tend to migrate from periphery towards the center. The result of PFTs may reveal a lowered value for the forced expiratory volume in the first second of expiration. However, the low FEV1 does not always correlate with the degree of radiographic abnormality. With PMF, patients can develop a mixed restrictive and obstructive pattern. Cold workers pneumoconiosis is also associated with Kaplan syndrome, which is the combination of pneumoconiosis and rheumatoid arthritis. This is a chest X-ray PA view in a patient of simple cold workers pneumoconiosis, where you can find multiple tiny radio opacities noted in the bilateral lung fields. They usually measure 1 to 5 mm. Here, the calcification is usually a central dot-like, which is a contrasting feature to those which occur in the silicosis, where you can find a peripheral eggshell calcification, and here it is a central dot-like calcification. Axial CT chest in a lung window in a patient of cold workers pneumoconiosis, where you can find multiple tiny nodular opacities in the bilateral lung fields. Here there is a little difference when compared to the opacities in the silicosis, where the margins are well defined in the silicosis, and here the margins appear little irregular. Chest X-ray PA view in a patient of complicated cold workers pneumoconiosis, where you can find bilateral symmetrical opacities in the upper zones which are moving towards the hila. This is a coronal CT image in a patient of PMF post contrast, where you can find bilateral nodular densities in the upper zones which are converging towards the hila, together with areas of calcification within the nodules. What is the importance of following up a case of PMF? Why should we follow? It is to rule out the presence of tubercular granulomas carcinoma, which gives an appearance which is very much similar to PMF. MRI can be helpful for distinguishing between PMF and lung cancer. The latter typically appears as T2 hyperintense, whereas PMF appears as a T2 hypointense lesion. On nuclear imaging, PMF can be FTG avid. Biopsy is the final stay to differentiate between the two entities. This is an axial CT lung window in a patient of cold worker pneumoconiosis, where you can find bilateral irregularly marginated large nodules in the bilateral upper lobes, together with the tiny satellite nodules in the bilateral lung fields. MRI in a same patient which is showing symmetrical T2 hypointensities, which is consistent with fibrosis. This is an axial T2 weighted MR image of the same patient, where you can find hyperintensity in the pleural cavity, which is consistent with effusion. This is a PET CT in the similar patient, where you can find there is avid FTG uptake in the bilateral upper zones and also in the right paratracheal node. This is in a patient where you can find a mass lesion in the T2 image, which is hyperintense. The similar image on the axial T2, and this is the coronal image in the lung window. This is the mediastinal window. So this patient has been given contrast, and in the post contrast you can find there is enhancement of the lesion. So a mass which is hyperintense on T2 with the post contrast heterogeneous enhancement is in favor of bronchogenic carcinoma, which is a contrasting feature of PMF, where the lesion is hypointense on T2. Follow-up is required in such cases to look for the progression of the lesion. If the lesion shows rapid increase in size, it indicates carcinoma. Follow-up of once every 5 yearly is recommended. Then coming to berylliosis, it's a chronic granulomatous lung disease which is caused by exposure to beryllium dust or fumes. Exposure may occur in ceramics manufacture, nuclear weapon production and aerospace industry. Acute beryllium disease is rare. Chronic beryllium disease develops in up to 16% of exposed workers depending upon individual genetic susceptibility and the extent and type of exposure. Symptoms usually include dyspnea, cough, fever, anorexia, and weight loss. Recognized as a cause of lung carcinoma like silicosis and asbestosis. Skin lesions are the most common extrathoracic manifestations, but granulomatous hepatitis, hypercalcemia, and renal stones may also occur. It's characterized by non-caseating granulomas. Histopathologically, it is indistinguishable from sarcoidosis. So, how to confirm a case of chronic berylliosis? It is a granulomatous inflammation that has to be proved at lung biopsy. Sensitivity and also by sensitivity of beryllium on the blood test and also through bronchoalveolar lavage. Axial CT chest in the lung window where you can find multiple nodular densities in the bilateral lungs together with the interstitial thickening. The other findings include honeycombing, ground glass opacities, bronchial wall thickening, hilar and mediastinal lymphadenopathy. Hard metal pneumoconiosis. The diagnostic criteria of hard metal lung disease include the following. They are a history of exposure to metal dust, characteristic clinical features which include shortness of breath, cough, and dyspnea on exertion over a prolonged period, radiologic and histological findings of interstitial lung disease or a giant cell interstitial pneumonia with thickening of the interstitium. Then the last criteria is a histopathological finding of metallic content within the lung tissue. This is a chest X-ray PA view in a patient of hard metal pneumoconiosis where you can find subtle nodular opacities. Axial CT chest in a patient of hard metal pneumoconiosis where you can find reticular densities noted along the subpleural location. Some other findings include ground glass opacification, consolidation, traction bronchiectasis. In the advanced cases, it may show honeycombing pattern. Coming to talcosis, it's a hydrated magnesium silicate. The recognized causes of pulmonary talcosis, each of which results in a different form of disease, are the following. It can be an inhalation of pure talc or talc in association with silica, which is called talcosilicosis, or talc in association with asbestos fibers, which is called talcoasbestosis, or it can be an intravenous ingestion of talc, which occurs most often during recreational drug use. An axial CT chest in the lung window where you can find areas of pericicatricial emphysema noted over here together with the areas of ground glass opacification and also few areas showing interlobular septal thickening and also dense areas of consolidation in the bilateral lung fields. Then coming to non-fibrotic group of pneumoconiosis. It is caused by the accumulation of iron oxide in macrophages within the lung. The siderosis is observed most commonly in the workers exposed to metal fumes during welding and thus is known as welder's siderosis or arc welder pneumoconiosis. The next type is barytrosis. It is caused by inhalation of barium particles, usually barium sulfate. Inhaled barium particles can lie in the lungs for years without producing symptoms or causing impairment in the lung function. Then coming to stenosis. Tin oxide is deposited in lung tissue after inhalation. Tin oxides, that is stannous oxide and stannic oxide. Barytrosis and stenosis are characterized by dense nodular opacities in bilateral lung fields. The differential includes pulmonary alveolar microlithiasis. This is the axial CT chest in a lung window in a patient of siderosis where you can find multiple small poorly defined centrilobular nodules. Other changes include emphysematous changes in about 33% of the subjects likely related to smoking, and there can also be honeycombing resembling that in usual interstitial pneumonia, and there can even be ground glass opacifications. Conclusion.
Occupational history and duration of exposure plays a key role in the diagnosis of pneumoconiosis. Imaging plays a role in order to distinguish between the sequelae of pneumoconiosis from complications like tuberculosis and carcinoma, which is very important in order to plan the management of patient and also for long-term follow-up. The final stage of diagnosis is through tissue biopsy. Thank you.